great privilege to have all of us gathered here today on this second national the Knowledge Management and Learning event. This is a follow-up to the event we had last year, and it's nice to see all the colleagues, all the team members gathered here from many different countries. So for us to be able to go on with the day, we have a busy 3 days that is going to be quite engaging, where all of us are going to be involved in many different activities, ranging from presentations to varied discussions around ANC, PNC, and there is the other aspect of the work, the pre-service training on midwifery, and also the CPD and competencies of the trainers in the medical training colleges. So indeed we have a busy schedule. So to be able to start us off, we will have a word of prayer, followed by introductions. Then we go to the substance of what we need to do for the day. So I will ask our colleague Helen Mutsi from Ministry of Health Kenya to facilitate with the prayers.
Okay, please let's stand for a word of prayer. Okay, let's pray. Father, in the name of Jesus Christ, we come before you. We thank you for this beautiful day that you've made for us to gather here and have a discussion. We pray that, Father, you may give us knowledge, wisdom, and understanding in whatever we are going to do. For it's in the name of Jesus Christ that we do believe and pray. Amen. Thank you.
Yes, thank you very much, Helen. So to start, my name is Dr. Rael Mutai. I am the Regional Technical Advisor for Lstm for Kenya and Tanzania. And at least, you know, it is nice to put names to faces, especially colleagues that we've not seen before. So we will go on to the introduction of participants, and because we are many countries represented here, it is really a colorful event. We have the staff of Lstm, we have colleagues from Togo, we have colleagues from Tanzania mainland, we have colleagues from Zanzibar, we have a team also from Nigeria, and of course our Kenyan counterparts from the ministry and other places. So, and also representative from some of the teaching institutions, more so those that are doing midwifery and nursing. I believe most of them will be here tomorrow, but there are a few who could as well be represented today. So we will have it is important that we get to know who is who in the room, and I propose that we do it according to the country. So maybe we will start with colleagues from Nigeria. I will request that you stand and introduce yourselves. Your name, your designation, and the institution you represent.
Okay, good morning, everyone. My name is Dr. Hawa Mohammed. I'm an obstetrician by training, and I'm the country director for Lstm in Nigeria. It is nice to be here, and like she said, it's nice to see faces that we've met so many times on meetings with. So nice to meet all of you, and I hope we have a great time together. Thank you.
Thank you very much, Awa. We have the other colleagues from Nigeria.
So, good morning, everyone. I'm Nefisat Musa Isa from Kaduna State Primary Healthcare Board, Nigeria. I'm a public health nurse by profession, and I'm a Deputy Director, Family and Community Health Services. Thank you.
Good morning, everyone. My name is Adacha Boslam from Lstm Nigeria. I'm the operations manager in Nigeria. You're all welcome.
Our other colleague is having breakfast. When she comes, we'll introduce her.
All right, so we will see her when she comes. Next, let's have colleagues from Tanzania, Tanzania mainland and Zanzibar.
Good morning. Habari za asubuhi. Dr. Mzee from the Ministry of Health, Assistant Director, Directorate of Reproductive Maternal and Child Health. I've come here in the place of Dr. Makwan, who is the Director. Thank you very much.
Thank you very much, Dr. Mzee.
Yes, good morning, everybody. My name is Leonard Katarambura from the University of Dodoma. I'm overseeing the implementation of the project in Tanzania mainland.
Other colleagues from Tanzania?
Good morning, everyone. It's so nice to be here today. My name is Maria Angelica Remamu. I'm from Tanzania, from the University of Dodoma. I am a second-year PhD student, and I'm also working under the project of quality improvement and integration of HIV and TB malaria in ANCPNC. Thank you.
Good morning. I am Wajuma Mdoe. I am a midwife specialist by profession. I'm from Tanzania, University of Dodoma. I'm the co-PI. Thank you.
All right. Thank you very much. The team from Togo? Yes, neighbors, you are not forgotten. Yeah.
Thank you. Good morning, everyone. My name is Salma Abdi Mahmoud. I'm obstetrician and gynecologist from State University of Zanzibar. I'm a project leader from Zanzibar. Thank you.
Good morning. My name is Mansab Ramazan Mansab. I'm from the State University of Zanzibar. I'm work package leader.
Good morning, everyone. My name is Zainab Hassan Suleiman from State University. I'm a PhD student of Lstm, second year student. Thank you.
Good morning, everyone. My name is Dr. Camille Ali Omar, obstetrician and gynecology by professional, and program manager in reproductive and child health programs. Zanzibar.
Yeah, so thank you very much. We'll move on to Togo.
Okay, thank you. My name is Professor Guillaume Kofivi Ketan, University of Lomé. I'm the focal point of the project in Togo.
Morning, everybody.
Good morning.
Doji Kanke, Monitoring and Evaluation Officer, University of Lomé.
Good morning. Daniel Musiamba. I'm in charge of strengthening health of the Global Fund Management Unit of Togo. Pour ceux qui comprennent français, voilà. Je suis le responsable du renforcement du système de santé à l'unité de gestion du Fonds mondial à Lomé. Merci. C'est un plaisir pour moi. Je vous parle un peu français aussi, hein, parce que vous allez me bombarder tout à l'heure. C'est un plaisir pour moi d'être ici pour pouvoir participer à cet atelier d'échange et de partage sur les activités du projet Liverpool qui se mène également au Togo. Nous connaissons les actions en matière d'amélioration des soins en CPN et en CPON. Donc c'est vraiment un grand plaisir pour moi d'être ici. Merci.
Thank you very much. Marion, you can give a brief.
Yes, good morning. I'm not from Togo, but okay. I'm Marie. I'm a senior research associate at Lstm, based at Liverpool, and I'm working with the Togo team on the project.
Thank you very much, Marion. So we go on to Kenya colleagues. I think we have quite a number of our colleagues from the ministry, from the counties, and I think we will have all of them introduced.
Start with the...
Okay, morning once again. Helen Mutsi from Division of Reproductive and Maternal Health. Thank you.
Any other Ministry of Health or the county teams, maybe? Can start from Vihiga.
Good morning, everyone. My name is Veronica Musiega. I'm a midwife specialist. I work in Vihiga County, coordinating reproductive health services. Very keen on ANC PNC project, and I'm here to share knowledge and learning. Thank you.
Thank you very much, Veronica, and most welcome.
Good morning, everyone. I'm Abigail Osendi. I work in the Department of Health, Vihiga County, head division of family health. and I'm one of the implementers of this project in Vihiga County. Thank you.
Thank you. Garissa? Oh, Derek. Oh, sorry.
Good morning, everyone. Good morning. I'm Dr. Induse Benjamin. I'm the County Director for Health, Vihiga County. Thank you.
Anybody else from Vihiga? No.
No.
Garissa? Let's start with Fatuma.
Good morning. Assalamu alaikum wa rahmatullahi wa barakatuhu. My name is Fatuma Iman. I am maternal newborn health specialist coordinating RH and maternal health in Garissa County, and I have been with this program from the initial start. Shukran.
Good morning and assalamu alaikum. My name is still remains Charlie Abdi from the Department of Health, Garissa County, and I do coordinate health planning and health information system, and I believe I'm a stakeholder in contributing better maternal health services for this country. Thank you.
Most welcome, Abdi.
Good morning. Assalamu alaikum. My name is Habon Golo Abdi. I work with the Department of Health, Garissa County. I am the head of Family Health Services. For this meeting, I'm representing the County Director for Health.
Most welcome.
So, Uasin Gishu? Oh, sorry. Karibu.
Good morning, everyone. Dr. Jason, Chief Officer, Uasin Gishu County Health. Thank you.
Good morning, everybody. Dr. Evans Kiprotich is my name, the Director Health Uasin Gishu.
Karibu Daktari.
Habari ya asubuhi. Yeah, my name is Meli. I'm an specialist in charge of reproductive health in Uasin Gishu County.
Karibu.
Any other Ministry of Health?
Yes, so moving on to other partners, I think we have representation from other partner organizations, like I think there is somebody from M-Mama or some, is there a colleague? Yes.
Good morning. My name is Dorothy Koech, Country Director in Mama Kenya from Vodafone Foundation. Thank you.
Thank you, and last but not least, the Lstm colleagues can stand and introduce themselves.
Okay. My name is Onesimus Maina, Technical Officer working with Lstm Kenya. So I can go to Irene.
Thank you. Morning, everyone. My name is Dr. Irene Nyaoke. I'm a Senior Technical Officer working with Lstm Kenya. I support the in-service capacity building. Thank you.
Good morning. My name is Dr. Lydia Mwanzia, Midwifery Educator, Senior Research Associate, working with Lstm. Thank you.
Where is Duncan?
Morning, everyone. I'm Duncan Shikuku, Senior Technical Officer, Liverpool School of Tropical Medicine, Kenya.
Good morning, everyone. I'm Martin Ainda, Technical Officer working with Lstm Kenya.
So that is it for the Kenya office. So colleagues from the UK office?
No, you still have
Director.
Lucy.
Good morning. My name is Lucy Nyaga. I am the Country Director, Kenya. Welcome.
Lstm UK.
Thank you. Good morning, everybody, and welcome. My name is Dr. Helen Allott. I'm an obstetrician and senior specialist in the department in Liverpool. I'm going to be helping to update the training materials. So if any of you in the course of the next 3 days have got any issues with the training materials that you feel are out of date, please come and tell me, and I'll bear that in mind as we do the update. Thank you.
Thank you, Len.
My name is Alice Ladu, and
postdoctoral research associate. I'm based in Liverpool.
Hello, my name is Felicia. I am the program coordinator of the unit in Liverpool.
Good morning, my name is Fiona Dickinson and I'm a postdoctoral research associate based in Liverpool. Thank you.
Okay, so I think we have some of our colleagues out there.
There's one lady here. Can't hide.
Hello everyone, my name is Rahmat Abubakar. I'm a second year PhD student based in Liverpool, Lstm. Thank you.
So thank you very much. As you bring the mic to Professor, I think we also have a support team providing us with technical support in communications, led by Meshach. Meshach, wave to the people so that they know you. In case of communication things, you can reach out to him. So thank you very much for those warm introductions. I think now we have an idea of who is in the room, and at least following of, you've also been given a sheet of paper that has the names of the participants. So in case you need to catch up with them, you can just reach out to them directly. Maybe get their contacts, their emails, if you need to communicate with them on anything that might be of interest to you. So we move on to the next item in the agenda. And in the agenda, we have welcome remarks from Professor Charles Ame, who is the head of the Department of International Public Health at Liverpool School of Tropical Medicine. Welcome, Professor.
Good morning, everyone. It's lovely to see friends and colleagues again. Some of you have known for quite many years, coming to Kenya or working in your countries. I think we work in partnership to try and improve the quality of care for women. And I think we take this event seriously because I think there's really no point trying to reinvent the wheel. We can all learn from each other, learn from our mistakes, and learn how to use the least amount of resources to make the greatest gain. So it is with this and against the backdrop that we're midway into the SDGs. And if you look at some of the big reports published by the WHO this year, ending preventable maternal mortality and the Every Newborn Action Plan, the progress report, which focuses on skilled birth attendants, antenatal care and postnatal care, which are key issues we address through this program, you'll see that we have not made a lot of progress. The programs in which we work at various levels, national level, subnational level, and we strengthen the quality of care in specific facilities. So over the course of the next 3 days, we're going to be sharing a lot of what we have learned. And we have some colleagues who are joining us online. They are not able to be here. We're probably expecting over 100 people from various organizations, partner institutions, research colleagues, implementation colleagues, and all of that. So I just want to welcome you, and I want to thank the Kenya team for all the hard work put together to organize this. Our partners in comms for all the fantastic work, very good products. I'll talk a bit more about the overview of the 3 days, when I speak later on. But just to say welcome, for those of you who are new to Kenya, it's a beautiful country, I can tell you. There's lots to see, lots to enjoy, and, let's make the best of it. Let's network, most importantly. I think there's a lot we can learn from each other. So thank you, Real. I hope I have not exceeded my 5 minutes.
So thank you very much, Professor. So we all know, as he says, midway to SDGs, 2030 is not far, it's just 7 years away. We are off track, and the issue is, so what do we do now? And so as we deliberate to set the ground for us, some of the presentations that we shall be hearing about is about how ANC and PNC aspect of the work of the continuum of care is being implemented in all our different countries. So before we start listening to those presentations, I will welcome Helen Mutsi on behalf of the Ministry of Health, Republic of Kenya, to make some remarks on behalf of the ministry, and straight on go to give us some highlights on how ANC and PNC is performing and what are the issues emerging currently in Kenya. Thank you and welcome, Helen.
Okay, morning once again. So on behalf of Ministry of Health, Division of Reproductive and Maternal Health, Kenya, I'm standing in on behalf of my head, Dr. Serem and Dr. Bashir. So our colleagues from Nigeria, Togo, Zanzibar, Tanzania mainland, UK, counties represented here. I know we have Garissa, Vihiga County, and Uasin Gishu. Partners represented, feel welcome. We really appreciate what you guys are doing on the ground in terms of postnatal, ANC, TB, HIV. You are really assisting us to achieve the ICPD 25 objectives of zero preventable maternal mortalities through your interventions, zero unmet need for family planning, and zero harmful cultural practices. One of them is early teenage pregnancies, FGM, and child marriages. So as a ministry, we welcome you. Feel at home. This is Kenya, Karibuni. I don't know whether Nigerians, you understand, and the Togolese. If I say Karibuni, it's just welcome. Feel at home. Mutembe around within Nairobi. I know you've come, you are loaded. Please make sure you leave what you came with in terms of cash in Nairobi. So please, when at the end of the sessions, don't just sit within the hotel. Move around. Kenya is very safe. So when it comes to the interventions, on ANC and PNC, we've worked closely with Lstm. Lstm, kudos for that. You've really helped the ministry to achieve its interventions. We've really worked with you on EMOC. If you want to understand what EMOC is, everybody will speak about Lstm. And that is what pronounced what Lstm is. And when you are starting these interventions for ANC and PNC, we worked with you. You aligned the manuals to the guidelines. We have the revised guidelines for the national guidelines for quality obstetrics and perinatal care 2022 that we have aligned to the WHO, and we've contextualized it to the Kenyan setup. So as a country, we are doing very well when it comes to antenatal care. If you look at our KDHS 2022, at what percent are we? The Kenyans represented here? It is even online. At what percent are we in terms of antenatal care? We are at 89%. That is a plus for us. But we want to capture the remaining percentage. So the fourth ANC, we were doing at 65, but we've done great strides. Because if you look at the KDHS statistics, we were at 52. So we moved to 65%. But we are not yet there. But at least we can appreciate ourselves through the support of partners, Lstm being part of them. We've really improved. So the interventions that we are giving in ANC and PNC is going to impact on the skilled birth delivery. As a Kenyan country, we are encouraging all our mothers to deliver at the health facility. So as a country on skilled birth, we are at 89%. Sorry, the ANC we are at 98%. Correction, So we are really doing very well. Kenya, I think we can applaud ourselves. Can we appreciate ourselves? We are at 98% ANC coverage, but the skilled birth is we are at 89%. But we need to capture the remaining 11%. Where are they delivering? We don't want them to deliver at home. We want them to deliver in the health facility. So as a ministry, we've incorporated the TBAs, the traditional birth attendants. We want them to work with the mothers in the labor rooms, in our health facilities. Let them become birth companions for these mothers. And we've encouraged counties to come up with whichever interventions that can bring these traditional birth attendants to the health facility with their clients. So I know counties have come up with various interventions for meeting this. There are some counties that are giving a token. There are some counties that are going up to the grassroots to do advocacy and sensitization to the TBS. So as a country, we are not yet there. We want to achieve the 100%. We want all our women to come for antenatal care. We want all our women to come for the PNC. So as a country, we've gone to the 8 contacts. We've adopted the WHO recommendation of 2016 model of 8 ANC contacts. So it is something we've started because we launched our guidelines in last year in July. So it's something that we started last year towards the end of the 8 ANC contacts. And we've moved around the counties to educate them on how they are going to bring out these interventions. So Lstm, thank you so much for what you are doing at Uasin Gishu, Vihiga, and Garissa counties, and we are encouraging you to move around all the 47 counties. So, Mr. Charles, can you up your funding so that you can support the ministry in reaching out to all the 47 counties? I know we have other partners who are also supporting the ministry, but we encourage all of us to be able to bring that intervention at the service delivery point so that you are able to capture these mothers to come for the ANC and PNC. I know the first ANC that is done within 48 hours, we are not doing well. My Kenyan colleagues, what % are we? The first within 48 hours. Msiega, where are we as a country? Yes, PNC within 48 hours. %, fast within 48 hours. Okay, that is kudos for Vihiga County, but as a country, we are not doing well. The first PNC within 48 hours, we are at 27%. Yeah, if you look at the KHIS report. And the issue is that we have, because of free maternity care, we have high volumes of mothers delivering within facilities. So we haven't done much in terms of infrastructure. So you find that these mothers are being discharged earlier within 24 hours, but we are insisting that mothers should be discharged at least within 48 hours, not before 24 hours. Because studies are showing us most mothers normally develop the secondary PPH within 24 hours, and they end up dying. And as we see, most of our mothers die because of PPH. PPH is our first killer of our mothers. And on maternal mortalities, we are not doing well. Slight improvement from the KDHS 2014 from 362 to, if you look at our population census report, to 355 per 100,000 live birth, but we are on the core. We want to achieve 0 preventable maternal mortalities as per the ICPD 25 objectives. So thank you so much. Feel welcome. Hope you are going to have a very active and interactive sessions. We are going to learn from Nigeria, learn from Togo, Zanzibar, UK, and Tanzania mainland. What interventions that you are doing that make you stand out, that are evidence-based. So thank you so much. Karibuni.
So thank you very much, Helen, for those remarks from the Ministry of Health. And of course, just by what she said, we know the burden that is in our hands. Some of us have been working in the sector for very many years. The question is, sometimes I feel like if they ask a question, how many people have been working in the health sector for 20 years? Lift up your hand. 20 or more years, lift up your hand. 30 years. Okay, so in fact, let's clap for them. That's really a long time. Can you imagine? You've been working in MNCH for those many years. I think you're making such a big contribution, and we appreciate your input. So we will have a couple of presentations just providing an overview of the ANC PNC situation in the different partner countries. So we will go straight to Nigeria. I don't know if it will be presented by one or two colleagues because of the two states implementing the project. And I believe, this is a knowledge management and learning event. There is so much to learn. We discover that we are similar in many ways. And most of all is that all of us are guided by the global policies and strategies on what is working best. The only challenge is sometimes some of these things that are known are not universally available and accessible. So welcome, my sister. So coming on is Navsat Musa Isa from Kaduna State. She's the director of primary health. Deputy Director of Primary Health in Kaduna State. Welcome.
Good morning once again. I stand here to present the overview of quality improvement of integrated HIV, TB and malaria services in ANC and PNC for Kaduna State and Oyo State, Nigeria. I'm Nafisat Musa Isa, a Deputy Director in charge of Maternal and Childhood Division, Kaduna State Primary Healthcare Board. And with me in the presentation is Dr. Olubimi Ainde from Ministry of Health, Oyo State, Director of Public Health. So in my presentation, in the outline of my presentation, I have Nigerian maternal and child health statistics. Okay. So I have maternal and child health statistics, the health system in Nigeria, healthcare in Kaduna State, collaboration to deliver quality ANC and PNC services in Kaduna State, success, missed opportunities, recommendation in Kaduna State, background of Oyo State, ANC, PNC services in Oyo State, as well as the challenges and recommendation. So in the background, Nigeria, being the 7th most populous country in the world, has an estimated population of 213.4 million people of different ethnic groups, where we have 3 major ethnic groups in Nigeria, which include Hausa in the north, the Yorubas in the south, as well as the Igbos in the east. For ANC attendance, Nigeria is at 67%, while skilled birth attendance is at 43%. The maternal mortality ratio is at 512 over 1,000 live births, indicating that 5 out of 1,000 women died during childbirth, which is quite high. And for neonatal mortality rate, Nigeria is at 67% over 1,000 live births. That is the map of Nigeria. So for the health system in Nigeria, the health system is governed through 3 tiers of governments. That is the local government authority, the state government, as well as the federal government. For the PSC is funded through the local government. The secondary centers are funded through the state government, while the tertiary institution is funded through the federal government, even though we have some tertiary institutions that are funded by the state government in both the 2 states. The fragmentation of funding source affects the health system in Nigeria, as each state is independent, leading to differences in remuneration, cost and quality of care. There is inadequate infrastructure, limited access to service, to quality of medical services, unequal distribution of health resources, especially in the rural areas, where about 55% of population lives. The healthcare workers are more in the urban areas because the tertiary institutions are more in the urban areas because of better working environment as well as take home. So for Kaduna State is the 3rd most populous state in Nigeria, following Lagos and Kano State. and it is situated in the northwest region of Nigeria, has 23 LGAs, 255 wards, and an estimated population of over 10 million, with 2.5 million of women of childbearing age in the state. There we have over 1,500 functional primary health centers with 30 secondary facilities, 5 tertiary institutions, and over 500 registered private as well as faith-based facilities. Recently, there has been an expansion of PHS and implementation of healthcare insurance scheme in the state in order to expand and increase access for coverage. The ANC accessibility is influenced by geographical location, socio-economic status, and cultural belief. Despite an increase in the ANC utilization, disparities remains in the state, highlighting the need for targeted intervention in the state. The state has implemented strategies to enhance ANC coverage, which include community engagement, health education campaigns, training of healthcare workers, among others. So for LSTM in Kaduna State, Liverpool School of Tropical Medicine, in collaboration with the State Minister of Health, as well as the State Primary Healthcare Board, with the support of Global Fund, are implementing intervention on quality improvement and integrated HIV, TB, and malaria services in the state. The program started in 2020 using the ANC and PNC platform for critical expansion of integrated disease prevention, screening, and management of women and children. The program is improving quality of healthcare workers through evidence-based quality integrated care in ANC and PNC through competency-based training. The intervention is supporting 60 facilities in Kaduna State within 10 LGAs. These facilities also receive donations of equipment from Liverpool School of Tropical Medicine in order to improve ANC and PNC services within those 60 facilities. So this slide is showing the data comparison from the baseline, that is when we started in 2020, and 2022, where we have seen for ANC 1, we started at 11%, while in 2022 we reached up to 30%, that is the blue line. And for ANC 4, we started at 26%, that is the orange bar, where in 2020 we were able to reach up to 44%. And for ANC 8, we started at 10% in 2020, while in 2022 we were able to reach up to 18%. So the next graph is showing PNC, where we started at 29, and at 2022 we were able to reach up to 82%. And for SBA, that is skilled birth attendant, we started at 11%, and we were able to reach up to 89% in 2022, based on our DHIS 2. Then for IPT, that is intermittent preventive treatment, we started at 10%, and in 2022 we were able to reach up to 32%. So, and pregnant women who received HIV counseling and testing in ANC were able to get up to above 34,000 differences between 2020 and 2022. And for maternal and newborn death, in 2020, for maternal death, we're at 243, and we reduced to 193 in 2022. And for newborn death, we're at 84%, and we're able to reduce to 54%. So for success stories, we are able to have an improved healthcare capacity to improve services through implementation of standard-based audit in the state. And we also missed the opportunity of not involving community structure at the start of the program, which is key for us in Kaduna State, where whatever we are doing, we need to engage the community at the initial stage. So we recommend scaling up to more LGAs and more facilities in order to expand and reach more women for us to see better impact. So I will hand over to Mrs. Dr. Bumi for her to continue with Oyo State. Thank you so much.
Good morning, everybody. I'm Dr. Olubunmi Ayinde. I'm the Director of Public Health in Oyo State. I'll be presenting the Oyo State picture of the activities we've had in Oyo State. So we'll be starting with the background of Oyo State. Actually, Oyo State is located in the southwest of Nigeria, and we have a population of about 9.8 million. We have 33 LGAs in the state, and we have 351 wards across Oyo State. We have 1,478 health facilities, which have been broken down into 858 public facilities. Under these public facilities, we have 3 tertiary facilities, 55 secondary facilities, and 800 primary health care centers. We have 620 private health facilities. Those private health facilities are not the total private health facilities in the state, but these are the private facilities that have been registered under the Ministry of Health in Oyo State. And we have over 1,004 traditional birth attendants in the state who also provide services across the state. For health personnel in Oyo State, we have about 5,500 health personnel that cuts across different cadres, from doctors to community health assistants to CHUs in the state. And that is what we presently have in the state. The LSTM program actually started in 2020. I'll be reporting the achievements that we've had. They actually cover 60 facilities across 10 local governments, and we can see that we have 33 local governments. So there's still so much space to expand. They've trained about 500 people on ANC, PNC, and we have a healthcare personnel of about 5,500. They've also trained over 200 people on quality improvement. They've set up quality improvements across all those 60 facilities, and they have a quality improvement team with community members as part of the community improvement team. This is to ensure utilization. We will still see the effect of that across the 60 local governments. They are covering 10 LGAs, and we have 33 LGAs in the state. We have 30 mentors that oversee activities in these 30 local governments across the state. And so far, each of the 30 mentors have been able to mentor 5 people per mentor. And we are gradually expanding. Another set of 5 mentees will have actually commenced mentorship. So the LSTM also provide equipment to these facilities to improve their service delivery. So what have we been able to achieve over time? This is for antenatal total attendance. We can see that in 2018, we had 8,000 people that had total antenatal attendance across the 60 facilities. In 2020 and 2021, we were affected by COVID. There was a drop, but it gradually picked up again. And as at end of 2022, we were able to have over 90,000, and that was due to interventions across these 60 facilities. For antenatal care force visits, we will see that this has actually increased across this facility because of the quality improvement team and the standards and intervention that has actually been put in place across these 60 facilities. We also have for HIV testing in these facilities. We have been able to improve HIV testing also in these facilities. We still have gaps, and this will actually show us the gaps. If over the period we had about 59,000 people in our ANC attendance, we still had a shortfall for syphilis testing, for hepatitis B testing, and even for HIV testing, because we expect that everybody who attends first antenatal care actually has access to this service in the different local governments. We have challenges, and part of our challenges and the recommendation is on the screen. We have inadequate health personnel across the facilities. We have inadequate commodities, including equipment, because the client flow into these facilities have actually increased. Inadequate monitoring and supervision We monitor them once in a quarter, and this doesn't give enough time, though the mentors are also there to provide services. We have challenges in documentation, which could actually affect some of our reports because the reports are from DHIS2. We have lack of regular review meetings to ensure best practices. If these facilities could actually have regular review meetings, it will help in learning from each other and help in achieving best practices and implementing these best practices. Then not all LGAs have been covered. And presently, we still also have a challenge. I mentioned the issues of traditional birth attendants in the states, and people still deliver there. For delivering facilities, according to the MICS survey, we are at 75.5%. We still have 5% of women who could actually add to the mortality and morbidity in the states. Looking at what is our recommendation, scale up of services, we are looking at the need for scale up, then involvement of private facilities, because 60% of our population in Oyo State actually attend private health facilities. Leveraging on existing ATM system, that is leveraging on the HIV, TB, and malaria structures in the state. This could also help in ensuring that services are provided adequately. Then provision of more equipment and involvement of the community structures, as mentioned earlier by my colleague. We have some events gallery. We can see where the mentors are actually mentoring and mentees in the facility, which is actually the first slide. That is this slide, where the mentor is actually putting the mentees through. Then here is Kaduna State picture, where they have a mobile van that provides integrated services across the state. And here also is still also a mentorship process, providing services in postnatal care for one of the women. That is our presentation. We would like to acknowledge all the systems that has made this possible, from Oyo State, Kaduna State, the Liverpool School of Tropical Medicine, the Federal Ministry of Health, the Global Fund, Johnson & Johnson. We sincerely appreciate your support to ensuring success in our services. And these are all the systems that have actually been put together. At this point, I would like to say thank you very much for listening. Ashanti Sansi. Sana. Thank you very much.
Yeah, thank you very much, Dr. Olubumi. Thank you very much, Dr. Navisat. Listening to both of you, you just get the whole a summary of the situation across most of our countries. So, before we go to the next presenter, I want to remind you that we have hashtags, we have organizations we can tag. You know, it's important for visibility that you are on X, yeah? That you find yourself saying something about this event, because now that you're here and you've been making a big contribution to this, if you go to page 7 of the booklet that you've been given, you will find some Twitter handles. Of course, now I don't know whether the Twitter handles are appearing on X. Yeah, so you go look for X, and then you can start tweeting and tag the organizations. You know, Lstm, the donors, Global Fund, Takeda, all the partners, ministries, the ministries of health in the many different countries, the universities that are in the projects, the county government or local government authorities, wherever you come from. Yeah, so just check that social media toolkit, and as the presentations are being made, it would be nice if you can follow Lstm Kenya and the units, the Lstm EMOC, the at Lstm MNHQOC. Yeah, if you follow that, you should be able to see what we are putting out there. So following on the Nigeria presentation, we will go straight to the Tanzania presentation, and we have two presentations on ANC PNC overview, one done by Camilla from Zanzibar, and the other one by Dr. Mzee from mainland Tanzania. So I don't know who comes first. Yes, Dr. Mzee, most welcome.
Asante, asante sana. Good morning again. Now, before I proceed, I should take this opportunity to convey our greetings from Dr. Makwani. He would like to be here. Dr. Ami, he says thank you to you and all the members from Lstm. He's very fond of Liverpool School of Medicine. I don't know what you did to him. It is always in his heart. So here we go. I will be presenting the Tanzanian mainland part, and my colleagues will present the Zanzibar part. Now, we have a short presentation about ANC, PNC services in Tanzania, and the outline of my presentation is as it is seen on the whiteboard. We shall start with the introduction, and then we shall go to the burden of malaria, tuberculosis, and HIV in Tanzania, because that is what we want to integrate in the services. And ANC and PNC strategic interventions for positive pregnancy outcome. And then we shall go to some of the key antenatal and postnatal care indicators. And then improving the ANC and PNC service delivery. And then we shall end with the challenges. Ladies and gentlemen, our Tanzanian maternal mortality ratio stands at that number. According to the UN estimates 2020, it was 238 per 100,000 live births. But from the TDHS, the last one, 2015, it was 556. But we have a new value, which is going to be announced recently in the few coming weeks. And we have made a tremendous improvement in that. So let us wait for that number. I think you should have your ears open, because there's a very, very tremendous improvement, to the extent that they are afraid of releasing that value. Okay, so we are improving. We are making progress towards SDG 2030. I think we are going to get through the targets. Antenatal and postnatal care can reduce maternal and perinatal deaths, as it is known, if we can detect the risks much more earlier. And in Tanzania, we are implementing these two interventions, which are scientifically proven to improve maternal and neonatal outcomes, as I've said before. Now here is the burden of malaria, tuberculosis, and HIV in Tanzania. If you look at the demographic and health survey and malaria indicators survey, which was done in 2022, the prevalence of malaria in the general population was 8.1%, and that is a bit higher. I think it was because of COVID-19. Some of the interventions were not properly being implemented. And if you compare it to malaria indicator surveys of 2017, it was a bit lower. The prevalence was about 7.5%. But for pregnant women, according to the DHS 2022, it was about 7.7%. No, it was 6%. But according to the DHIS 2 in 2021, it is about 7.7%. It is relatively low, and this is mostly prevalent in lakes regions and the coastal areas. But for the highlands, the prevalence is a bit lower. For tuberculosis, it is taken in the general population. Currently, we don't have tuberculosis intervention at the antenatal and postnatal care services, so it is not integrated. So we have taken the number for the general population. That is the value we could get. The incidence is about 208 people per 100,000 population. For HIV, there's an intervention in the antenatal and postnatal clinics. And for the general population, the prevalence is 4.7%, according to the surveillance that was taken in 2017. But according to the antenatal surveillance in 2021-22, the prevalence is about 6.2%. I've mentioned this because these are the areas where we want to have strong integration in antenatal and postnatal care services. Now, we have several strategies for improving maternal health and also newborn health. First, we encourage people to attend antenatal clinics as soon as they find that they are pregnant, so that we can have some interventions at the early booking. We encourage them to come to the clinics at less than 12 weeks. The uptake of this intervention is not very good. We are below 50%, 12 weeks attendance. And we have another strategy of detecting and managing preeclampsia as one of the leading causes of maternal deaths. So in that, in every visit, the women have their blood pressure being taken. We also check for urinary proteins. And the other strategies are about prevention, detection, and management of malaria in pregnancy. And we screen all women who are attending antenatal clinics using malaria rapid diagnostic tests. And we treat all positive, MRDT positive women. On top of that, we are providing insecticide-treated nets for the women who are attending antenatal clinic, as well as implementing the strategy of provision of SP for intermittent presumptive treatment of malaria. Anemia in pregnancy, the strategy is providing the women with supplements, iron and folic acid, their hemoglobin and blood groups taken. We also provide antihelminthics in the clinic, especially we give mebendazole for deworming. And for mother-to-child transmission, we are screening most of the women who are coming to the antenatal clinics, and even if we have missed that opportunity, they are being screened at the postnatal clinics. Now in this area, we are doing quite great. The numbers are above 90%. The numbers of women who are being screened, the number of women who are getting the ARTs is above 90%, as we shall see in some of the indicators. And in prevention of transmission of congenital syphilis, we are screening the women for syphilis using RPR, and those who are found to be positive get treated. Now these two interventions, we are going to mix them up. Prevention of mother-to-child transmission of HIV, prevention of vertical transmission of syphilis. We are going to add prevention of mother-to-child transmission of hepatitis B, and we are calling it triple elimination. We are in the stage of disseminating the guidelines and building capacity to healthcare workers to perform this intervention. The seventh strategy is prevention of postpartum hemorrhage, and that is we implement the active management of the third stage of labor, and we encourage initiation of early breastfeeding. And the other strategy is about detection and management of complication in the puerperium. We are improving on the postnatal care according to the WHO guidelines, and we hope we are going to reduce that. For the time being, according to DHS 2022, the postnatal care within 48 hours has gone up to almost 80%. Because in Tanzania, we don't discharge women before 24 hours. So if you look at it this way, within 48 hours, we have a lot of women who have been screened for any complications before being discharged. So we are improving on a lot of indicators. Here I wanted to just highlight some of the indicators that we are tracking. Antenatal care attendance above 4 visits. According to DHS 2022, it is about 65%, but in DHIS 2, we are above 81%. So this one is, it was a survey. This one is real data from the facilities. So according to the DHS 2, we seem to be below 60. We are about 63, 65. But we are performing much more better than that. Antenatal care attendance below 12 weeks, we are lagging behind. These are just the data from DHIS 2, that is the routine data. I just wanted to show here for the snapshot. And pregnant women positive for malaria during antenatal visit, if you take the 2,628, 442, we had about 143 women who tested positive for malaria in 2022, and compared to the mid-year, January, June 2023, which was 82,571. If we duplicate this number, I think this year we may have much more women testing positive for malaria. But we are still, implementing the interventions that are going to reduce their chances of contracting full-blown malaria in pregnancy. Now for postnatal care indicators, we still have mothers who are delivering outside the health facilities, but they also come to the facility to get the postnatal care. So if you look at the fourth row, women who had delivered at home but had attended postnatal care within 48 hours, we had about 18,532 women in the last year, but this year we are still having some of them delivering at home. And breastfeeding is okay. This is a percentage of children or newborns who are breastfed within 1 hour of delivery, 91.4% versus 91.7% in the mid-year. We are in the process of integrating the recommendation for WHO in many aspects of ANC, interpartum and postpartum care. One is to integrate the dietary advice in our antenatal care booklets. We have improved the booklet from the card. Now we have an illustrated booklet with various illustrations of varied diets which the women can take during the pregnancy. We are also including intimate partner violence and gender-based violence in our new booklet. And as I've said, tuberculosis was not included in the first RSH card or antenatal care card, but we are going to include this in the booklet. We are working on task shifting by employing community health workers, and we are going to adapt the 8 contacts from the focused antenatal care, which was about 4 visits for the whole period of the pregnancy. We also provide delivery kits during antenatal care. From the 28th week, the lady will be given a clean delivery kit so that she can use it whenever she goes in labor, whether be at home or anywhere she can use it. Take it to the labor ward when they start labor. And we are continuing with on-job training, especially mentorship instead of the class training. These are the strategies in the groups. We are working on the capacity building, data management, quality assurance, and human resource. I have highlighted the number of healthcare workers employed because I don't have the exact number to tell you. But, because in the fifth phase government, there are no employment. There was the exercise of culling out those who had fake qualifications, who had entered the health sector and the public sector. So there was no implement. But from this sixth phase government, the government has started employing, and we are narrowing the human resource for health gap. Now it is about 52% from the previous one, which was about 70%. So the government is still employing, and these other things, as I've said when I was presenting in the other slides. Now the challenges, we have several challenges. On the part of commodities, there's an unstable supply of maternal health commodities, especially when we are at the era of COVID-19. We are recovering. We hope that is going to be better, but funds, the budget is short of the Abuja agreement. We are still improving on that. Infrastructure, especially antenatal care services. We have a lot of women coming for antenatal care, but the infrastructure is not adequate. There are a lot of women without, proper sitting position, and that also goes with shortage of staff. Maybe one staff is attending about 400 women for a day. It's a tedious work. But now we have new antenatal care and postnatal care guidelines, and some of the healthcare workers are not aware of those guidelines. But some of the workers have some attitude that is, I think, is cross-cutting. And for the public, some of them do not know the importance of attending the antenatal and postnatal care visits. And we have the environment where the service is being delivered. This comes with the healthcare workers, some of them with the negative attitude, but also with the overcrowding. So the environment becomes a bit unfriendly, and some people do not like to engage in this, going to the clinics. But we also have the problem with the male engagement. We are encouraging the partners to accompany the ladies to come to the clinics. We are still working on that. I think it will be taken gradually. And before I continue, before I end my presentation, there are some of the things that are being implemented. Like a mama, the country is now rolling out. We expect that by the end of this month, the whole country will be implementing the community transport system that is called M-Mama. I think you also implement it in Kenya. So we are going to roll it out to make it easier for the women to be transported to the health facility and the newborns too. And we are disseminating, we are at the stage of disseminating the labor care guide. We want to discard the old patograph because the evidence shows that the labor care guide has a positive pregnancy outcome compared to the older patograph. So we are in the process of doing that, and we hope with this improvement we are going to improve the pregnancy and newborn outcome in the country, and reach the target that has been set for 2030, that of reducing maternal mortality to 70 per 100,000 live births and perinatal deaths to 12 per 1,000 deaths. Having said that, I thank you again for listening. Asanteni sana.
So thank you very much, Dr. Mzee. Listening to you also raises quite some pertinent issues. And we really appreciate when the challenges faced in a country, you've organized them very well. We can see the supply side factors, the health system, the health worker related issues. We can see also the place of the social determinants of health, so that, you know, sometimes as healthcare people, we just want to think around the Ministry of Health, and maybe some issues can be sorted by people in transport, maybe people in IT and the like. So to be able to address all the building blocks that are lacking. So thank you very much. And it's also nice to hear about a mama. Thank you, Director, that you're here. Maybe at some point you may be able to tell us a little more about how that approach works to provide transport for people, especially during those critical times. So we will go on to the presentation from Zanzibar. Dr. Camilla, you have 10 minutes to make that presentation. Welcome.
Okay, good morning, everyone. My name is Dr. Camilla. Okay, I'm going to present about antenatal and postnatal overview in Zanzibar. Most of the things are presented in general by Dr. Mzee, so I'll go more detail in Zanzibar parts. Okay. Concerning about maternal mortality, as Tanzania mainland explained, there is some improvement in maternal mortality. For example, in 2021, we had MR about 134, and in 2022, according to Health Bullet, we had MMR of about 99 per 1,000 live birth, per 100,000. So in Zanzibar, we are just to follow the 80 visits during antenatal according to the RAMCA strategic plan 2019-2023. So these 8 visits help to improve the outcome of maternal and neonatals. It can help for the increase of health facility delivery, and also it can help with some of behavioral changes, especially during ANC, like counseling about nutrition, newborn care, how to initiate the initial breastfeeding, and counseling about the family planning. So in Zanzibar, the ANC coverage, first below 20 weeks, we still have a low number, 25.7%. In 2022, this is low compared to the strategic plan that we are supposed to have below 12 weeks. Our target is at least 34%. And for the first contact, there is a decrease of ANC visit from 2021 of 82.8% to 71.6%. And for fourth contact and above, we had 33.5% in 2022. But there is a bit of improvement for overall the 8th contact from 1.6 to 3.5%. Coming to the routine ANC data, for the HB testing, it is the same almost from 2021 to 2022, from 63.7 to 63.3. And for the blood sugar testing, it was a bit increased. 2021, it was 47.2, and in 2022, it is 49.9. Coming to malaria testing, for the 2021, we had 55.3, but the 2022, we had 17.6. And this testing was decreased because, according to the Zanzibar guideline, we are just testing for those who have a symptom of malaria. It was not routinely testing. That's why the percentage was decreasing. because the malaria, according to the research, the malaria positive for the pregnant woman, it was 0.1%. That's why we test for all those who are coming for the sign and symptom. And concerning to HIV rates, actually the overall testing for the HIV is above 95%. And for those women during pregnancy who are tested for HIV positive, it is less than 1%. It was 0 point something, so less than 1%. Syphilis, so we had the challenges in ANC syphilis testing, and this is because of the sometime unavailability of tests for the syphilis kits. So, however, there are some improvement from 2021. It was 2020. It was 51. 2021, 20.7, and 38.6 in 2022. So, for Zanzibar, malaria, I think the past year it was not a big problem during pregnancy, but we had a big issue in anemia. It still is very challenges in anemia. And as year goes on, we see there is some increase of anemia in pregnancy rate from 1.29 to 1.5 in 2022. So also concerning of PNC visits within 48 hours after delivery, the data show there is some reduction of PNC visit within 48 hours. Like previously, we have 86.5. So there is a lot of challenges concerning on how to improve the ANC and PNC. The first challenge is it was a health facility. There was poor infrastructure of some of health facility, inadequate of commodity. So currently, Ministry of Health, together with some donors, have started have renovation in some of health facility, and they finished to almost 11 district hospital, which was started in 1st September. So still the Ministry of Health continue to renovate and build another regional hospital. That's the plan that's going on. On service delivery, still there are some poor quality. This is in terms of health facility. Also capacity building was a problem. So still there was continued capacity building through Ministry of Health with collaboration of different donors like UNICEF, UNFPA, LAD, JAPIGO. So together still different training and mentorship and supervision are going on to improve this quality of care. Coming to human resources, still we have a shortage of skill power in different cadre. It was difficult to put the actual number, but we have a different shortage, especially like currently we opened this 11 district hospital from the 1st September, so still the shortage of staff was low. Last year, the ministry employed about 700 different cadre, and other donor, they employed for the contract 2 to 3 years of different cadre also, but still there is a shortage of human resources. And coming to the data, this is a major issue in data quality and supervision. So still supervision on data quality are going on to improve the data, because when we going to do the supervision most of the time, especially this DHIS2 data, the district health information, so you can inequality of like the filling of the data from the register form and the actual data that they are filling. So thank you very much.
So thank you very much, Dr. Camilla. So we've had the progress that they're making in Zanzibar, which is really positive because, you know, their MMR is it's at 99, and we are looking for the model figure from the rest of Tanzania coming soon, which is, I want to believe they have hit the SDG target for Tanzania. So we are very hopeful. We'll wait. We'll keep our ears open. So thank you very much. We will go on to the last presentation for this session, the one from Togo. Dr. Musiamba, to make the presentation, please.
Just before Mr. Musiamba presentation, just to tell you that all presentation from Togo will be in French to allow Francophone participants to be more integrated in the event, but obviously the PowerPoint presentation will be in English. So if you have any question, you can still ask, but I think it's enough detailed in the presentation, and I hope you will enjoy some French during your day.
Merci. Donc, comme annoncé par Marion, je vais faire la présentation en français. Je vais essayer d'être posément pour permettre à ceux qui peuvent comprendre de comprendre. Donc, je suis Daniel Musiamba. Je suis responsable des activités de renforcement du système de santé à l'unité de gestion des projets du Fonds mondial. Ça marche pas ton truc. Ok. Ici. D'accord, merci. Donc, nous allons faire une présentation en 3 points. D'accord. Nous avons présenté les statistiques générales du système sanitaire. Nous allons présenter le système de santé au Togo, l'organisation à travers son plan national de développement sanitaire. Et puis, il va faire un petit focus sur l'unité de gestion des projets du Fonds mondial, UGP. Donc le Togo, pour ceux qui ne le connaissent pas, c'est un petit pays de 5600 km², une population de 8 400 000 au dernier recensement de 2022. Le pays compte 6 régions sanitaires. 6 régions, la savane, la Kara, la centrale, les plateaux et la maritime, qui est divisée en 2 régions parce que la région de Lomé est une région sanitaire Grand Lomé. Donc 5 régions administratives, 6 régions sanitaires. En termes de statistiques générales sur les interventions liées au VIH, à la tuberculose et au paludisme, de façon générale, l'utilisation des services en 2021 est de 56%. Je rappelle que nous avons préféré utiliser les données facilement vérifiables par tout le monde, c'est-à-dire les données d'enquête, donc les données de l'EDST et les données de MIX. C'est pour ça que vous allez voir les références, les données de ça date de 2021. Donc l'utilisation des services est de 56% en 2021. Nous avons noté 298 cas sur 100 000 habitants de paludisme en 2021 et la prévalence du VIH est de 1,9% en 2021 et on a noté 33 cas sur 100 000 habitants de tuberculose en 2021. Donc, en matière de santé maternelle et infantile, SMI, ce que nous appelons SMI, les statistiques sont comme suit. La mortalité maternelle est de 401 pour 100 000 habitants. La mortalité infantile de 42 pour 1000 habitants. La consultation prénatale, ce que nous appelons la CPN 4, est de 55%. Les accouchements assistés par du personnel qualifié, 45%. Et les femmes qui ont bénéficié d'une consultation postnatale dans les 2 jours elles sont 71%. Pour la prévention de la transmission du VIH de la mère à l'enfant, pour diminuer la transmission du virus chez les femmes qui sont sous ARV, on a 68% de femmes qui étaient sous ARV en matière de PTME. La distribution des moustiquaires, 33% de ménages dans la population générale et 40% de femmes enceintes ont dormi sous moustiquaire la nuit dernière selon les dernières enquêtes. Et au niveau de la prévention de la transmission du paludisme chez les femmes, ce que nous appelons la TPI, 88% de femmes ont bénéficié de la sulfate d'oxypyrimétamine à première dose et la troisième dose, 41,67%. Ici, nous faisons un petit focus sur des projections. C'est les indicateurs de notre plan national de développement sanitaire 2023-2027, ce que nous appelons le PNDS. C'est des projections qui ont été faites à l'aide du logiciel One Health, entre autres. La mortalité maternelle, on se projette d'ici 2030 de la réduire de 401 à 225. Et la mortalité néonatale de la réduire de 27 à 10 pour 1000 habitants, bien sûr. Et la mortalité infantile de 88 à 25. Et la prévalence aiguë, la prévalence de la malnutrition aiguë chez les enfants de moins de 5 ans, on va la réduire de 6,5 à 1,5. La prévalence de la malnutrition chronique chez les enfants de moins de 5 ans, on va la réduire de 27,5 à 3. C'est très ambitieux. Et les grossesses chez les adolescentes, on compte la réduire de 4,25 à 28. Selon ce plan national de développement sanitaire, si ces interventions sont implémentées de façon équitable et juste, on pense pouvoir sauver 1120 vies de mères et 23 529 vies d'enfants d'ici 2027. Lisez 2027, s'il vous plaît. Et ici, c'est juste pour dire que au Togo, en dehors du plan national de développement sanitaire, nous avons une politique d'amélioration de la qualité des soins. Et cette politique, c'est sur la base de cette politique que sont implémentées toutes les interventions en matière de soins. Et cette politique est basée sur la route de Deming, que tout le monde connaît, hein, d'accord? La route de Deming, planifier, faire, évaluer et puis améliorer en continuant. Donc permettez-moi ici de vous faire un focus sur l'unité des gestions de projets du Fonds mondial d'où je viens. Au Togo, les projets du Fonds mondial sont gérés par un récipiendaire unique. C'est la primature de la République togolaise, contrairement à d'autres pays. Donc c'est ce récipiendaire principal, le PIA que nous appelons, qui gère toutes les subventions du Fonds mondial au Togo, y compris le volet clinique et le volet communautaire. Et donc ici, la primature est ici, coordonne donc par le CCM. Nous avons un bénéficiaire principal qui est ici, qui travaille en collaboration avec le ministère de la Santé, et on a une centrale d'achat des médicaments, d'approvisionnement, qui coordonne tous les intrants au niveau du pays. Et au niveau des bénéficiaires, nous en avons deux types. Il y a des bénéficiaires cliniques, ici, ils sont 3. le programme national de lutte contre le VIH, ici là, le programme national de lutte contre la tuberculose et le programme national de lutte contre le paludisme. Et sous ces bénéficiaires secondaires, nous avons ce que nous appelons des bénéficiaires secondaires communautaires. D'accord? Sur chaque subvention, ici, au niveau du VIH, nous avons la plateforme des OSC qui en est la bénéficiaire secondaire, avec 7 sous-bénéficiaires qui sont en fait des ONG qui travaillent à la base, au niveau communautaire. Et au niveau de la tuberculose, on a l'Union des ONG du Togo qui est le sous-bénéficiaire secondaire, avec 9 sous-bénéficiaires secondaires qui sont vraiment au niveau communautaire et qui sont chargés de superviser l'activité des agents de santé communautaire. Et au niveau du paludisme, on a la Croix-Rouge togolaise qui est le bénéficiaire secondaire avec 21 sous-bénéficiaires secondaires au niveau opérationnel. Et le projet d'amélioration de la qualité des soins maternels et infantiles Lstm, en collaboration avec l'Université de Lomé, se trouve plutôt, la feuille devait être peut-être ici, elle se trouve sous la subvention paludisme. Pourquoi paludisme? Parce que c'est cette subvention qui supporte toutes les activités de renforcement du système de santé. C'est pour ça que la flèche est ici. Quelques chiffres financiers sur l'unité de gestion. Pour la période en cours 2021-2023, le Togo a reçu 98 856 160 € pour lutter contre les 3 maladies, dont 54 555 577 € pour la lutte contre le paludisme, 40 782 952 pour la lutte contre le VIH et 3 517 pour la lutte contre la tuberculose. Et entre-temps, vous le savez, à partir de 2021, il y a eu cette pandémie où le Fonds mondial a ouvert une fenêtre que nous appelons COVID, le C19-RM, d'accord, COVID-19 Response Mechanism, où nous avons reçu 26 415 275 € pour lutter pour renforcer le système de santé, pour renforcer la réponse contre les épidémies. Voilà ce que nous avions à partager avec vous. Merci beaucoup. Asante Sana.
Merci beaucoup, Dr. Musiambe. Really impressive presentation. As you can see, this is, I think, the maturest of the program. It's in year 4, so it's been implemented for quite a while. And as we continue with the 3 days meeting, we shall be learning more from what they have been able to do successfully, how they have surmounted key challenges, and more so how to really get to institutionalize the intervention so that they are not just left freely hanging and being forgotten at the end of the, because projects keep transitioning from one to another. So at this point in time, we are a few minutes late, but it's that time when we need to take we need to take a photo, then we take our tea break before we come to continue with the rest of the sessions and try to catch up on lost time. So the communications colleagues, can you help us on how to take where we take the photograph? Yeah, so we will take a couple of photographs. I think we will take them from within here, and then we'll take a short break, 15 minutes. We should be able to come back. Yes, to come back by 5 minutes past 11. Just. Yeah, please kindly let's just move quickly to the front. We take the group photograph for all of us and a couple more.
So, where is the photo? Please stand up here. So photo is outside here.
Stivo, tupembe zile banners. Umestop, umeenda. Wacha tu thumbnail peke yake. Eh? Nini?
Okay, let's step outside for the photo that is